Recording. Okay, so welcome to our general weekly group. I'm Wendy Myers. I'm one of the senior clinical managers at Cancer Bridges, and I oversee the support groups and counseling. And tonight we welcome Dr. Cottrell. So Dr. Cottrell is a board certified psychiatrist and a family physician, which is a rare find, and especially we're lucky to have her in Pittsburgh. It's great. She has both of those specialties. She moved to Pittsburgh from her native town of Kentucky in 2014. She completed a double board residency in psychiatry and family medicine at UPMC in 2019, and then took a position with Allegheny Health Network after graduation. At AHN, she provides outpatient psychiatric medication management for patients referred by their primary care providers, as well as general medical care for patients of all ages. Her career interests include integrating behavioral health treatment into primary care and other medical settings, and psychiatric care for patients with complex medical needs. So we welcome Dr. Cottrell, and I think she has some slides to share and just some information. And if you want to either put your questions in the chat as we go along, or at the end, I will stop the recording, and then we'll be able to ask questions freely then. Okay. All right. So welcome, Dr. Cottrell.
Well, thank you. That sounds great. Thank you so much for that introduction. I really appreciate it. And it sounds great that you guys, as you think of a question, put it in the chat. And as much as possible, I'd like to have a pretty sort of open, informal discussion, especially at the end of the slides. I'm a pretty informal person, as you'll probably see, although there are parts of this presentation that I think feel a little formal because they talk a lot about how do we diagnose psychiatric illnesses and who would be appropriate for medication-based treatment for those illnesses. That's kind of the crux of what we're doing today. But I guess my goals for today's conversation would just be to kind of empower everyone to feel a little more comfortable with knowledge of mental health medication, particularly antidepressants, because those are the most common ones that we're going to use and that you're going to see. And also to feel comfortable having conversations with your own doctors or your own providers or even family members or other people in your life about this type of medicine if you suspect that you might benefit from being on it. And again, I intend to leave a good amount of time at the end for questions as they come up, because that's why I'm here, like pick my brain. That's what I'm here to do. And so I will start up my slides here. Maybe. All right, cool. Okay, so let me pull up my slides here. And as Wendy said, I work for Allegheny Health Network. I trained at the other place. I trained at UPMC in Pittsburgh, so I worked for both entities. I won't get into a debate about who's better, but I've been happy to have a job at both. I'll put it that way. So today's presentation, again, the gist of it is how do we utilize mental health medication to help us emotionally in folks that are going through cancer treatment or who have been diagnosed with cancer. And as Wendy said, I sort of wear several hats. I am both a psychiatrist and a primary care doctor. So my role, or where I exist in the medical world, is straddling that line between the emotional parts of our well-being and of our health and the physical parts, and how they influence one another is something that really interests me and that I talk a lot with patients about. So I feel comfortable sort of talking a lot about mental health in patients that are struggling with medical illnesses and vice versa. So that is how we ended up here today. And maybe I can get the slide to advance. There we go. So the first thing I want to talk about, and these are things that I know you're all familiar with, concepts you're all familiar with. I mean, you participate in these support groups because I'm sure you want to be emotionally aware and sensitive. But folks that are diagnosed with cancer and undergoing treatment can obviously undergo a huge range of emotions, top to bottom. And you can see several that are listed there. And as we move forward through the presentation, what I'm going to do is try to group some of those emotions with to match them up with illnesses that we treat, diagnoses that we treat in psychiatry, so that you can have a sense of, again, do I have a mental illness? Do I have something that could be treated with medicine? And how do I know? And then what does that mean if I'm on medicine? So the first thing I want to really hammer home, because I think this is a common misconception, is that depression in and of itself is not an illness. Depression is a symptom or a set of symptoms. Any of us at any time can experience depression symptoms in response to something tragic, something horrible, something difficult, something we really can't sort of wrap our minds around, or that we feel overwhelmed by. And a lot of depression symptoms include the things that we might feel, after something like a cancer diagnosis: sadness, apathy, emptiness, isolation, despair, anger, guilt, hopelessness, denial. Those are all potential symptoms of depression. So how do we know when depression becomes larger than just a set of feelings in response to something tragic or something awful, and then becomes an illness? So this is where this is the part that gets a little boring and technical, but just so that you guys can understand, like, what are we looking at as doctors? What are we looking at when we diagnose somebody with an illness? A major depressive disorder is the term that we use. So for folks that have a major depressive disorder, an illness characterized by depression, that means that they have, for at least 2 weeks of all day, every day, that's how I describe it to patients, 5 or more of the following things. You've got to have persistent low mood or sadness, and or loss of interest in things that you would normally like to do. And I mean, like, it doesn't count if you're not interested in something that you wouldn't normally do. If you don't normally hunt, and when you're after you've been diagnosed with cancer, you decide, I don't want to go hunting, that wouldn't count as loss of interest. But then in addition, there are other symptoms that can come along with depression. So we need 5 or more of the following for at least 2 weeks: the low mood or sadness and loss of interest, and then disturbance in appetite. And interestingly, that can go either way. It can be overeating, it can be undereating, it can be weight gain, weight loss. In my experience, it's sort of, people can also vacillate between the two. They can gain weight, they can lose weight, their appetite can be really affected. Same with sleep. It can be undersleeping, oversleeping, some combination of the two, sort of pinballing back and forth. And again, these are things that must be different than they were when you're feeling at your best, when you're feeling normal. So somebody who has had long-term struggles with sleep and insomnia may not necessarily meet criteria for a major depressive disorder based on their sleep, based on the sleep disturbance piece, because it's been the case for a long time. So these must be new things. People often will find that their movements are impaired, the way that their body physically moves and feels. They may feel slowed, like they're walking through jello. They may feel restless, or sometimes people will use the word agitated, like they can't sit still, they can't relax. People will notice often impaired concentration. Another criterion that I think is really, really common in folks that are struggling with major depressive disorder is feelings of worthlessness or excessive guilt. And those are worthlessness feelings or guilt feelings that are disproportionate, that don't match up at all with the reality, right? The intensity of negative feelings really tends to be magnified in folks that are struggling with major depressive disorder. And then sometimes people will have thoughts of death, or thoughts of suicide. More often than thoughts of death, more often than thoughts of suicide, are thoughts of what we call passive death wish, which is like, I just don't want to be here anymore. If I didn't wake up tomorrow, that would be okay. That's actually a really, really common thought in folks who are struggling with major depressive disorder. And it may be a thought that folks are afraid to share because they're afraid the reaction might be really profound or that it might scare someone. But especially in the setting of a doctor's office, when you're kind of talking one-on-one with a provider, that's an important thing to bring up. And it is common amongst people that are struggling with major depressive disorder. So then the other thing that I want to make sure I hammer home too, as I discuss is, well, just so to kind of set the scene a little bit larger, there are three types of illnesses, three types of psychiatric illnesses that I'm going to discuss today in relation to how antidepressant medicine can help. There are lots of other psychiatric illnesses out there, but these are three of the most common, particularly in people that are undergoing cancer treatment and in the population in general. So some of our more severe psychiatric illnesses that you might hear about, like bipolar disorder or schizophrenia, are not covered in this talk. We're talking about three of the most common types of mental illnesses. So anxiety symptoms, in fact, folks that have been diagnosed with cancer or undergoing cancer treatment predominantly tend to more commonly present with anxiety symptoms as opposed to depression symptoms. And again, anxiety in and of itself is a symptom. It's not necessarily an illness just because you feel fearful, worried, you feel panicked. But then a lot of the same symptoms will overlap with depression as well. Things like avoidance and isolation, anger or irritability we often see with folks that are struggling with anxiety, denial as a way to sort of escape the reality of what's happening. But then again, similar to depression, when does it become an illness? When do we need to start thinking about treating it like we would any other illness? So this is one of the most common psychiatric illnesses that we treat in mental health. It's called generalized anxiety disorder, and it is characterized by excessive anxiety and worry. And I mean excessive, over the top. Like the average person would look at this and say, this isn't a situation you should be worried about, ideally. More days than not. So I usually use the term with patients all day, every day, worried all the time, all day, every day, for at least 6 months. So it's a very persistent, longer term illness. And it has to be pervasive across a lot of different spheres of your life, at home, at work, across a lot of different activities or a number of different events. The worry has to be difficult to control, and it associated with 3 or more of the following features. Folks that have generalized anxiety disorder are often restless. They feel keyed up. They feel on edge. They have a very hard time relaxing. They feel they're easily fatigued because they are so restless and keyed up all the time. They also have difficulty concentrating, just like we saw with major depressive disorder. They'll also often describe like their mind going blank, or they're having problems with their memory. They can become irritable, easily frustrated, short-fused, angry. They often have a lot of physical manifestations of worry, muscle tension, headaches, stomach upset. Those are some common ones that I see. And then sleep disturbance, as you might imagine. Folks that are anxious and keyed up and edgy have a hard time relaxing and settling down to be able to go to sleep as well. So insomnia is a common one we see. In order to have generalized anxiety disorder, in order to have the illness as opposed to just symptoms of anxiety, that anxiety, the worry that goes with it, and the physical symptoms that go with it have to cause distress or impairment in social, occupational, or other important areas of functioning. So it really has to get in the way of what you should be doing and what you feel obligated to do in your life. And/or I would say also significantly impair your quality of life. That's another kind of way to think of it. So again, I would say the person who is appropriately worried and sort of ruminating or thinking about their cancer diagnosis and what's the next step and what do I, because there's a lot to do at any, it's sort of, you get your marching orders and there's a lot on the agenda to keep track of. That appropriate worry is not something we would consider an illness or a disorder. It's when that worry becomes all consuming, starts to interfere with their function, their quality of life, they're avoiding avoiding people, avoiding social situations, avoiding their responsibilities, that sort of thing, that's when it becomes really an illness that we should look at treating. And then the last sort of illness or set of illnesses that I wanted to bring up that I think often get really overlooked or not talked about very often in folks that are diagnosed with cancer and undergoing cancer treatment are trauma disorders. And trauma symptoms encompass all of the above. All the anxiety symptoms, all the depression symptoms can be included in trauma. And we'll talk a little bit about what trauma means. But I can tell you, as somebody who is a physician and who works in the medical system all day, every day, we do not recognize or appreciate enough how traumatizing it is for patients just to be patients, to be in the hospital, to have to undergo treatment, to get a really scary, potentially life-threatening diagnosis, to feel invalidated or not heard by their doctors when they're trying to explain what they think, what they think's going on. Like, there's so many traumatic things that can happen. So I don't think we talk about that enough. But where those trauma symptoms become a disorder or an illness is when we start calling it, typically we think of post-traumatic stress disorder as being the illness that we treat in psychiatry here. It does require at least one or a recurring traumatic event. Typically that would involve exposure to actual or threatened death, for example, a severe illness or a hospitalization, serious injury, or sexual violence. For folks to develop post-traumatic stress disorder, they must have some degree or some form of intrusive experiences about those traumatic events. So that could be in the form of distressing memories that intrude upon your thinking, like you're going about your day, and then all of a sudden these really traumatic memories, really vivid, scary, upsetting memories from something difficult that you've gone through, just sort of intrude upon your thinking, and it's like you have no control over them. Nightmares, I think we're all familiar with that. Flashbacks, which is the tendency while awake during the day to relive, re-experience completely, as if you're transported back to the event, back in time, or relive a traumatic event. And then the other sort of way that people can re-experience trauma is through distress, physical distress or emotional distress. Now that could be panic attacks, it could be racing heart, it could be breathing fast, sweating, dizziness or lightheadedness. It could be fear when exposed to a reminder of some kind of the event, like a smell or a sound or a location that the traumatic event took place in. Folks with PTSD also have to display some amount of avoidance of those reminders. You could imagine where that might stem from. Like if you are in if you're in a traumatic situation that you tend to become very triggered to re-experience, very upset, very panicked, very emotional every time you re-experience it, you'll start avoiding those places, right? Those places, those things, those reminders, because you don't want to feel that way. We don't want to feel the negative emotion of it. So tendency to avoid is also part and parcel of what it's like to suffer from post-traumatic stress disorder. There also have to be negative changes in one's mood or thought patterns following the traumatic event, including two or more of the following. And these are common. Again, I see folks with PTSD all the time, but that could be inability to remember important aspects of the event. Sometimes we'll say things like people are amnestic, they have memory loss about the event. They often will have exaggerated negative beliefs about themselves, about others, or about the world. Like, for example, folks that have been traumatized often can feel very distrusting, very suspicious. There's a tendency to paint with a broad brush and say, I'm not safe anywhere. I'm not safe with anyone because I was made to feel unsafe or my life was threatened in this scenario before. They could have distorted thinking about the cause or the consequences of the event. For example, I often will see folks who have been through traumatic events who believe or start to believe that they caused it in some way, that they did something wrong, and that's what created the situation. If they had done something, if they'd done X, Y, and Z thing differently, it would never have happened. So those are distorted thoughts. Negative emotional states, so that's like depression, sadness, low mood, apathy, diminished interest in or participation in activities. That's also, as we talked about earlier, a core symptom of depression as well. Feelings of detachment or estrangement from others. So often struggles maintaining relationships, feeling connected to others, and the tendency to isolate. Inability to experience positive emotions. It's hard to be happy. It's hard to enjoy things. It's hard to be content. And then alterations in arousal or activity. So what I mean by that is the folks that are like really edgy, irritable, angry, short fused, reckless, or self-destructive. Often folks who've been traumatized can manifest some of their distress in things that are pretty self-destructive, like substance use, for example, risk-taking behavior, hypervigilance, which is kind of like the person who is always edgy and who's always suspicious and always like sort of waiting for the other shoe to drop. Exaggerated startle response, so like people who are like easily startled, easily on edge, easily upset. Concentration problems and sleep disturbance. So in this case, this illness can be diagnosed if these sets of symptoms have been persistent for at least a month. So it does not have to last as long. And often folks that have been through a traumatic event or a series of traumatic events will find that these symptoms, though they can persist for a few weeks after the traumatic events, often they will resolve by the time a month rolls around. Like not everybody who goes through something traumatic develops PTSD. But just like the other illnesses, they have to, in order for us to say it's an illness that we need to treat, it has to cause significant distress or impairment, right, in your life. It really has to get in the way of you functioning the way that you should, enjoying things the way you should, and your quality of life. All right, so let's get into like the good stuff. Now that we've talked about like the helpful bits about what do we do about those three most common psychiatric illnesses that may benefit from being on medication. So one thing we know about psychiatric illnesses in people with cancer is that they're common. It is an extraordinarily above and beyond stressful thing to be, a stressful state to be in, that a lot of us don't know how to relate to whatsoever. So 40 to 60%, so half, if not more, of people in cancer treatment experience some kind of significant emotional distress. So if I went all the way back to like that first slide with all those different emotions, some element of those is present in 50%, if not more, of people in cancer treatment. Of those, of all the people in cancer treatment, only 25 to 30% of them can be diagnosed with a psychiatric illness. So only 25 to 30% have severe enough and persistent enough symptoms that we say, okay, this person meets criteria for, let's say, major depressive disorder or generalized anxiety disorder or PTSD, for example, as some of the most common. We know that depression, there's been tons of research done on depression in folks with cancer and that are undergoing cancer treatment. I would say less research on folks with anxiety and PTSD, but we know that they are just as impairing, and anxiety particularly is even more common than depression. So you can kind of extrapolate what I'm saying about the research in folks in depression in folks with cancer to anxiety and trauma symptoms as well. But we know that people undergoing cancer treatment who have depression experience more physical symptoms, more side effects to their medication, more discomfort, more pain, and more fatigue. We know that their quality of life scores, the way that they would self-rate their quality of life, is lower. We know they're more likely to encounter negative thoughts. And you can kind of see the thought bubble there about what I mean with some negative thoughts and symptoms of depression. We know that folks with struggling with depression who are in cancer treatment have increased difficulty managing all the moving parts of their treatment, their physical health needs, their cancer treatment needs, all their appointments, all the things they're responsible to do, all the phone calls, everything that goes with it. They also tend to be less engaged or have less of a relationship with their cancer treatment providers and other doctors, and they're more likely to be in the hospital than folks going through cancer treatment that are not depressed. So, like, I guess trying to hammer the point home of why it's so important that we recognize it and why it's so important that we treat it. So how do we treat it? What do we do? What's the next step? Let's say we've identified either in ourselves or in someone we love or we care about that we think they're struggling with at least some symptoms of depression, anxiety, trauma or PTSD, folks who are going through cancer treatment. So typically our treatment approach is a combination of antidepressant medication and or therapy. And I'll talk a little bit about like who would be appropriate for which group and how do we determine who gets what. And again, this talk is just specific to antidepressants. There's lots of other mental health medicines out there. If anybody has specific questions about other mental health medicines, I can answer those too, but these are the most common, so that's what we'll stick to today. So one thing we know about antidepressants, and I don't know how familiar everybody on this call is with antidepressants. Guaranteed you all know somebody that's on one. We all do. They're extremely commonly prescribed in the United States. But the things I kind of want you to take away here are that there actually is no class, no group of antidepressants that's better than the other as far as treating symptoms of depression, of anxiety, of PTSD. However, there are reasons why we as the provider or as the prescriber might choose one medicine over the other. It mostly has to do with side effect profile and any other physical health symptoms that the patient or physical illnesses the patient might be experiencing in addition to their depression, anxiety, or trauma. But there's a lot of factors to consider. So the again, important thing to take away is that you can help us. Patients can help us determine what medicine is the right choice or what type of medicine is the right choice because you can tell us about what your previous experiences have been like with mental health medicine, what your family members' experiences have been like with mental health medicine. There is a component of genetics here. So folks that respond really well to one type of antidepressant or one drug, the folks they share DNA with also might respond very well. So these are important things for us to know. And honestly, the biggest thing is just for our patients to feel comfortable being honest about what they're struggling with and about their physical and emotional health needs so that we can choose sort of the right treatment plan. All right, so the most commonly prescribed class of antidepressants for anyone, not just people in cancer treatment, are the selective serotonin reuptake inhibitors or SSRIs. You don't have to remember that, but all you need to know is these are the first option for treating depression, anxiety, and trauma disorders in people with cancer and in people without cancer. The reason it's our first choice, because remember I said all those classes of antidepressants are actually equally effective. The reason this is our first choice is because they are better, they're easier to tolerate. They have fewer, less severe side effects than other classes of antidepressant, and they're just as effective. So why would we not use them? And interestingly, the two drugs in this class that are most commonly prescribed for patients with cancer because of the lower risk of drug interactions with chemotherapy and other cancer drugs are escitalopram, or Lexapro is the brand name, and citalopram or Celexa. And those are couple of drugs that folks might be familiar with. All right. There is a much older group of antidepressants called tricyclic antidepressants that we do still use sometimes, but not nearly as often as we do this previous class that I just showed you, the SSRIs. This class of drugs has its uses for sure, and they have been around a long time. However, we're kind of limited as to how often we use them because the side effects are pretty significant, harder to tolerate. And typically the side effects are what we call anticholinergic side effects. Again, you don't have to remember that, but it's things like drowsiness, sedation, constipation, dry mouth, sometimes weight gain, increased appetite. So those things can be hard to deal with sometimes, depending on the patient. These are also medicines that tend to have a lot of potential drug interactions, so they're a little bit trickier to use with other drugs, with other medicines. However, they are very helpful for chronic and neuropathic pain. And neuropathic pain is it can be a side effect of a lot of chemotherapy regimens as well. There can be sort of nerve damage that takes place as a function of the chemotherapy itself, and drugs like this can actually be quite helpful. A couple of examples of drugs that are used in this scenario are nortriptyline and dicipramine. Those are a couple with a lower side effect profile relative to the other medicines in that class. So again, we don't use those as much, but you might see them, and there might be a situation where we yep, Dave, you read my mind. We're gonna get to mirtazapine in a second. We're almost there. But yes, we'll get there. Mirtazapine is weird. It's in a class all by itself. So the more modern, the newer antidepressant group that's used more often to treat chronic and neuropathic pain, in addition to depression, anxiety, and trauma, are the SNRIs, the serotonin norepinephrine reuptake inhibitors. Again, you don't have to remember that, but they are safer from a side effect standpoint to take and from a drug interaction standpoint to take than those tricyclic antidepressants. The only thing we have to be careful about is in folks with high blood pressure. This type of medicine, because it affects norepinephrine, which is kind of like your adrenaline receptors, can worsen high blood pressure if we're not careful, but they can be used safely in patients with high blood pressure. We do it all the time. We just keep a close eye on things. Couple of examples of those. These are drugs you're probably more familiar with, or some folks have heard of. Those are venlafaxine or Effexor, and duloxetine or Cymbalta. Cymbalta particularly is used a lot in folks with chronic pain or neuropathic pain. All right, so then we get to our other antidepressants, and this is where mirtazapine comes in. These are antidepressants that are in a class all by themselves, but that we use a lot, depending on the need, depending on what symptoms the patient's struggling with. The top one there is called bupropion, or Wellbutrin is the brand name. That's probably what folks more have heard of. It is what we call a very activating antidepressant. It helps reduce depression symptoms and fatigue, helps with energy. The only, I would say, real downside to Wellbutrin is that it does not alone treat anxiety or trauma symptoms particularly well, but it is great for somebody who is, for the most part, just struggling with depression, and struggling with the tendency to oversleep, have low energy, overeat, that sort of thing. Trazodone is an antidepressant, an old antidepressant that is used predominantly for insomnia at this point. It's not a very powerful antidepressant, but it is sedating and it does help folks with sleep. It is used a lot of times in conjunction with other meds, and it is one that can be used on an as needed basis. It doesn't have to be taken every day. And then mirtazapine. Mirtazapine, or Remeron is the brand name on that one. That is a novel, in a class all by itself, antidepressant that is actually used quite a lot in folks that are chronically ill and in folks that are undergoing cancer treatment, because it has so many different uses. It is a sedating antidepressant, so it helps with insomnia. It treats depression disorders, anxiety disorders, trauma disorders, and chronic pain. And it also increases appetite for folks who are struggling with that. So chemo-related loss of appetite, for example. All right. So that's kind of like the overview, the bird's eye view of how do we know that someone may be struggling with a depression, anxiety, or trauma related illness that would need to be treated, and what drugs are out there, and how do we know which drugs are appropriate, and what drugs might be offered to us. But then, I think a lot of times folks, one of the sort of more common questions I'll get is just like, how do I start? How do I start this conversation if I think I might be one of those people, or if I think my loved one might be? So it is important to know actually who can diagnose psychiatric illnesses, and it's more people than you think. It doesn't have to be a psychiatrist. So therapists or counselors are trained. Those are mental health professionals. They're trained to diagnose psychiatric illnesses. Your oncologists and cancer specialists can diagnose psychiatric illnesses, primary care physicians, psychiatrists, and typically you've probably encountered one, if not all of those other providers before you would ever get to a psychiatrist. Psychiatrists are kind of hard to come by sometimes. I wish there were more of us, but there are lots of folks that work in medicine and in mental health who can help diagnose these illnesses if you suspect they're going on. And then who's appropriate, who benefits from antidepressant medicine? So like when I was saying earlier, if our treatment plan is therapy and medicine, who gets therapy, who gets medicine, blah, blah, blah. So typically antidepressant medicine is reserved for folks with severe symptoms, severe depression, anxiety, or trauma symptoms that significantly interfere with their function and or their quality of life. We reserve, for the most part, antidepressant medicine for those folks because a lot of people, when their symptoms are mild or moderate, will get better with therapy alone. And then we don't have to worry about the idea of introducing a new drug, introducing a new potential set of side effects, or any other problems that that we as doctors sort of create with all of our drugs into your body, and you can get better without that. But when things get very severe, there's actually a very good body of evidence and research that tells us that the best treatment plan is one that involves both medicine and therapy. Okay. And then, of course, well, like I just said, basically anybody with depression, anxiety, or trauma symptoms, regardless of how severe they are, could benefit from therapy. Nobody's going to get hurt by going to therapy at all. No side effects to therapy, at least not compared to medicine. So, and then also people often ask, well, who can prescribe antidepressant medicine? So if I'm going through cancer treatment, who can put me on an antidepressant? Your oncologist might feel comfortable. They certainly can, or capable of prescribing antidepressants. Other cancer specialists, your primary care doctor. In fact, in the United States, the vast majority of mental health medicines are prescribed by primary care doctors, not by psychiatrists. So which is, again, my other job. So primary care doctors tend to often be the first line of defense when it comes to all sorts of medical and mental health issues. So they're usually very comfortable prescribing antidepressants, and oncologists are too, because while you're in treatment with them, they tend to see you frequently. They tend to have the most contact with you. And then of course, psychiatrists too, but as I said, we're hard to come by, and typically we don't see folks until things are getting a little complicated as far as mental health medicine goes. All right, so I promise I'll wrap up here. Talked more than I thought I was going to, but here we go. So tips for success. What do I do if a provider of mine, a primary care doctor, my oncologist, my psychiatrist, decide that it would be a good idea, or they think it would be helpful for me to take antidepressant medicine? How do I set myself up for success? First of all, take your medicine every day. Antidepressants are meant to be taken every day consistently. They have to be in your body all the time to work well. And they do build up in your system over time to reach the full effect. So they do not work. They are not effective if they're only taken like on an as needed basis if you're having a bad day. So they're meant to be in your body all the time. And that's how they function as preventive medicine. Of course, please notify your doctor if you're uncomfortable or experiencing concerning side effects on your medicine. But bear in mind that most antidepressant side effects will improve or go away completely within 1 to 2 weeks after starting your medicine. So a lot of times what we'll say is, if somebody reaches out and says, I don't feel good on this medicine, my stomach is upset, I feel nauseated, I will say, that's kind of within the realm of normal and it'll get better the longer you take your medicine. If it doesn't get better by 2 weeks in, we may need to look at a change. But the most common side effect by far is stomach upset, which again gets better. And then antidepressants take about 4 to 6 weeks after starting them. They don't work right away, which is a limitation of that type of medicine for sure. But they take 4 to 6 weeks after initiating or after changing the dose to reach the full effect. So it's not going to be immediate. There may be a few dose adjustments we need to get you up to the point where you feel like you're more in control and like the volume has kind of been turned down on your symptoms. And if you decide, I would like to stop this medicine for whatever reason, please, please, please talk to the person who prescribed it to you or to another provider about how to do that safely. Ideally, it's medicines, antidepressants are tapered off as opposed to just being stopped cold turkey. And the biggest risk of stopping medicine cold turkey like this is not so much withdrawal symptoms, but the fact that your symptoms might come roaring back, your depression, your anxiety, your trauma. The big concern about not tapering off is that people just tend to feel lousy. The things the antidepressant was treating tend to come roaring back. All right, cool. And in some cases, you may not need to be on antidepressants forever. Often, folks do really well when their symptoms are managed for about 3 to 6 months, and we start looking at cutting back. So in some cases, it may be reasonable to say you don't have to be on this medicine long term. But again, we have to be thoughtful about how we come off of it and do it slowly and do it thoughtfully. It is, however, for people who tend to have persistent or long-term or recurrent symptoms of depression, anxiety, and PTSD, it is safe to continue these medicines long-term, even lifelong. And again, just a couple of other little points and then I'll be done. Antidepressants are just a tool. They're a tool in our toolbox to make emotions more manageable, to make these illnesses more manageable, but not to eliminate emotions completely. Our goal is not to medicate you to the point of not being able to feel things when it's appropriate to feel things. We want you to be happy when it's a happy time, sad when it's a sad time, etc. And also the other place to gain more tools to cope with emotional distress is in therapy or counseling, which is a lot of, I think, what you guys do when you connect as a group. So that's all I've got. And I think I left not as much time as I had wanted, but I allowed about 10 minutes for questions.
No, you're good. Thank you, Emily. That was amazing. That was wonderful. I've had a lot of mental health, talks in my career, as well as, over the years here. And that was so thorough, but easy to understand. So I'm going to stop the recording so that you guys can ask questions